Hello, welcome back everybody. Just in time for our next lesson on oxygenation and circulation skills. So this is Nursing 230. I've already covered content for oxygenation and circulation in 220. So this is going to be a little bit different and yet some similarities. If you have any questions, please post them to the questions in the Canvas platform under questions on the top. And in this particular module, I also have another section for questions where you can talk to each other or talk to me, and you're able to respond to each other. So you might want to visit that as well if you want to get a discussion going about the content. So let's just get started. All right. So we have already talked about the anatomy, but I'm just going to go over it again because, again, things you need to know. So the lungs, again, pair of spongy air-filled organs that sit in the chest or the thorax. And the trachea is called the windpipe. It conducts inhaled air into the lungs through branches called bronchi. Then the bronchi divide and they get smaller and smaller and smaller until they're bronchioles, and finally they become microscopic. The bronchioles end up in clusters of microscopic air sacs. Those are called the alveoli. In the alveoli, oxygen from the air is absorbed into the blood. And in the alveoli, carbon dioxide, which is the waste product of metabolism, travels from the blood to the alveoli, where it can be exhaled. And if you recall, if we keep in a lot of carbon dioxide, we tend to become acidic. So between the alveoli is a thin layer of cells called interstitium, and it contains blood vessels and cells that help support the alveoli. And you also have to remember that the alveoli have surfactant, which helps them remain open. The lungs are covered by a thin tissue layer called the pleura. The pleura. The same kind of thin tissue lines the inside of the chest cavity, and that's also called the pleura. So we've talked about this before, and you've had it in anatomy. One is called the visceral pleura, and one is called the parietal pleura. Do you know which is which? So there's then a thin layer of fluid that acts as a lubricant, which allows the lungs to slip smoothly as they expand and contract with each breath. So again, those two layers of tissue, you don't want them, or membrane, you don't want them sliding together when they're dry, because that would cause a lot of pain for patients. And that type of thing is called pleurisy. One of the big things that we want to do as nurses is make sure that we maintain our patients' airways. We're always looking to make sure that their respiratory status is intact. So we want to position them adequately. Usually when people are having trouble breathing, either a high Fowler position, sitting up in a chair, sitting in a recliner, pillows, like extra pillows under their head, or a lot of patients in the hospital, if they're having trouble breathing, will sit up on the side of their bed and they will lean over a bedside table and prop their elbows up on the table. That can definitely help them breathe because it helps their lung expansion. Another thing to help your patients maintain their airway is to teach them about quitting smoking. Deep breathing and coughing, especially for people who are on bed rest or have had surgery, it's very important for them to take deep breaths many times an hour. And I will talk to you in a moment about a device that helps with that. So they would deep breathe and then they would cough. So they tries to get some of the secretions that might have built up in their lower bronchioles and alveoli up and moving out. If a patient has really thick secretions, one thing that we can also do is make sure that they are getting plenty of fluids, so maintaining their hydration. I've talked to you before in NUR 220 about chest physiotherapy and how the respiratory therapists will come to a patient's room and position them in certain ways and hit on their chest or use a special type of vibrating device. And again, that will help mobilize secretions by doing that. So on your screen now is a picture of an incentive spirometer, and I'm sure that you have heard of that before. I've mentioned it before. This is a device that we use to help people maintain their lung expansion. So it's very useful for helping or to help prevent pneumonia in patients. This should be a standard when we're caring for post-surgical patients because a lot of times they are in so much pain they don't want to breathe. So if we give them some kind of goal to reach, that is very helpful for people. So we want to encourage the person to use this device 10 times an hour while they're awake. We don't go in the middle of the night necessarily and wake them from a nice sleep to do this. They need their rest too, but they can do this on their own. They do not have to have a nurse in there to help them do it generally. But if they are forgetful or they just maybe don't want to do it, or they are in a lot of pain and don't want to do it, it would be good every hour when you're doing your hourly rounds to pick it up and ask them to perform 10 nice breaths. So with the incentive spirometer, it has several different parts. On the left side, on the colored photograph here, that little piece bobs up and down, and that's called the indicator. So that is called an indicator because it indicates whether the patient is maintaining a nice breath during performing this exercise. So that's the indicator on the left. You see it's got a flexible, that's the corrugated blue tubing. Then there's the mouthpiece. There is a marker in yellow on the right-hand side, and that's where it moves up and down, and you can set that and tell a patient that that is their goal. That's their incentive. If you slide that yellow marker up to, let's say, 1500, that is their goal to reach 1500 liters. So The white is the piston part. It's kind of like a little rubber plunger, like in a syringe, the little black part in a syringe generally. So it's the same type of thing, and it moves up and down. And the top portion of that is where you measure what goal your patient has reached. So that moves up and down. So in the module, I have a video that I want you to look at. It is on incentive spirometry. And the video has some questions. It will ask you, it'll stop and ask you questions, questions that I have put in there. So make sure that you look at that. Then there's continuous positive airway pressure. You've probably heard of CPAP before because we hear a lot about it because we hear a lot about sleep apnea these days. So we usually think of CPAP like this, sort of like this anyway. So a little machine that delivers air to a patient through a tube, and they have a mask on their face. So what this does is continuous. It's continuously blowing air toward their face. So it is keeping their airways and their alveoli, hopefully their alveoli open, but definitely their airway. So there's always pressure against their mouth and their nose, pushing the air in. So that's positive pressure. So this is what we usually think of when we think of positive airway pressure, is that people will wear one of these masks at night when they sleep. A lot of the masks are not full face masks like this, but they are many times just on the person's nose, covering the person's nose. Positive airway pressure can also be delivered by a ventilator, like people who are in ICU, to keep their airways open as well. Oxygen therapy. So how is it supplied? In the hospital, we have wall units that are connected to big tanks that we can't see, but they're big old tanks on the opposite side of that wall that get changed out. You probably know and have seen the little portable tanks that are green, and they're metal. They are heavy, and that you have to change the little oxygen regulator. I'll show you that on the next slide, but there's an oxygen regulator. I think I had one of those in class in 220 to show you all, but I'll show you that again on the next slide. You also have oxygen concentrators, and that is what is shown on the screen on the right. These are portable, so people can take them with them. These days they have ones that people can wear over their shoulder, so that's really nice that they can, people can get out and get around now. So safety issues with oxygen therapy. Again, oxygen is a flammable gas. Not only is it a flammable gas, but it is also a medication, and that's something else that you need to remember. We need to keep this flammable gas away from open flames and we need to keep the flames away from the gas. So no cigarettes, sparks, or anything like that. No smoking around oxygen sources. You'll see signs in hospitals and clinics about if there's oxygen in use, people are not to smoke. Another consideration for hospital and home and clinics is that people should definitely have electrical systems updated in their homes. You know, if they live in an old home and they have to be on oxygen, they might want to consider updating, their electricity, because you definitely don't want any sparks flying, and the electrical appliances that are used need to be well grounded. So 3-prong electrical plugs should be used. Also, around the face, we don't want to use any petroleum products on our patients if they're on oxygen, because again, flammable gas, and petroleum is also flammable. So no, like Vaseline on somebody's lips or something like that. So should not have petroleum products around oxygen. Aerosols are like little tiny particles, which are not good for somebody's airway anyway. So if somebody's on oxygen therapy, that is not good for the lungs to begin with, but then aerosol cans are, that's also a flammable substance. And then there is also acetone. And if you don't know what acetone is or is contained in, that is fingernail polish. There's a lot of fumes with fingernail polish, so again, not good for the respiratory system, also very flammable. Another consideration is keeping oxygen tanks secured, and this applies to both or all hospital, home, and clinics. They need to be standing and hopefully in some kind of upright holder. They need to be vertical in storage. We do have, there are carts, gurneys that we have to, transport oxygen with the patient sometimes when we are transporting them around. And generally, some of the newer models of carts or gurneys have a special holder in the bottom of them, but it is not completely flat. It's at least a little bit tilted. So you don't really want to have oxygen tanks that are laying horizontal. So again, oxygen delivery systems. We talked about nasal cannulas. In the class in 220, and there is a picture of a nasal cannula on this screen in the right upper corner. Then there is the simple face mask, which is just basically the plastic mask that goes over the face, but there are air holes to allow the carbon dioxide to leave. And the partial rebreather and then the non-rebreather. The Venturi mask, what is pictured on the lower right of the screen here is the face tent. And then there's also a tracheostomy collar. So these are the other modes of oxygen therapy, some other modes of oxygen therapy. I think they're all on here now. So simple face mask, top left. What I called a Christmas tree before, I called a Christmas tree, and it goes on the regulator. So from top left to right is a simple face mask, a Christmas tree, a regulator with a Christmas tree, and that's what the oxygen tubing will hook up to. The tracheostomy collar, and then on the bottom left is the non-rebreather. And for all purposes, you need to know that the form of oxygen delivery that allows for the highest concentration of oxygen to be delivered to the patient is the non-rebreather. I don't know if you remember it in class, but I showed you how to fill the bag that is on that device with oxygen before you ever put it on the patient. Do not put this device on a patient's face without that bag being filled with oxygen because they will suffocate. The lower right shows a Venturi mask and how a Venturi mask works. There is room air that comes in to the device along with 100% oxygen, but the amount of oxygen that gets to the patient can be highly regulated by using this Venturi mask. So they do ABGs a lot on people who have oxygen delivery systems like this, so they can adjust the level of, or the concentration, I should say, of oxygen, percentage of oxygen that the patient is getting. So just remember that 100%, or sorry, yeah, the non-rebreather delivers 100% of oxygen, which is the highest concentration of oxygen that can be delivered by a device. Oropharyngeal airways. Again, I think I had a sample of that in class. C-shaped hard plastic inserted into the mouth and into the pharynx. It keeps the tongue from going back into the throat and blocking the airway. So you measure it from the front of the teeth. That flange there should be at the front of the teeth to the end of the jawline. There is a video that I will put in the module section on how to properly insert these devices into a patient's mouth. Nasopharyngeal airway is called a nasal trumpet. It's very flexible rubber tube that is inserted through the nostril and again keeps the airway open. It goes into the pharynx. You measure this from the nares to the end of the jawline. That's how long it should be. So these are not comfortable devices for people, so many times they go into people who are semi-conscious or unconscious, or just waking up, let's say, from anesthesia or something like that. So there are lots of uses for these, but generally we don't put them into conscious people that are fully awake. Number one, the airway, the oropharyngeal airway would gag somebody. And you don't want to elicit a gag reflex and have somebody vomit and then aspirate. So this is a video that I will upload to the module in Canvas so you can watch it. All right, suctioning. So how do you know that a patient needs to be suctioned to begin with? We suction, first of all, to remove the secretions, and our goal is to maintain the person's airway. So suctioning is just one way that we can do that. Another thing we can do to help is to turn them on their side. Let's say they're laying in bed and they vomit. and they're laying on their back, well, we need to not only have a suction device there at their bedside, but we can also turn them on their side so that gravity will help the secretions flow out. So how do we know again that a patient needs to be suctioned? Well, a lot of times they become agitated and restless, and most of the time you can hear a gurgling sound, or they'll be like coughing. They're trying to cough, but you can tell that they're not successful in getting stuff up. So they may be having difficulty breathing that you can see. You can put a pulse ox on them if they have a decreased oxygen saturation. That may be an indication that they need to be suctioned. So if you go in to assess a patient and you take their pulse ox and you notice that it's lower than it should be, like in the low 90s, upper 80s or less, less would be bad, but you might want to listen to their lungs, because you may not be able to hear without your stethoscope that they have a lot of stuff built up in their lungs. So they may need suctioning of some sort if their oxygen sat is low. I'm not saying they do need for sure suctioning, but they may need suctioning. Another way you can tell is that their heart rate and respiratory rate increase, and a lot of times that is because they are agitated or getting agitated, or they are, you have to think physiologically what else is happening in their body. If their airway is not clear, what's happening? If their tissues are not getting oxygen, their heart rate's going to increase and their respiratory rate is going to increase to try to compensate for that. Their tissues saying, oh, I need help, I need oxygen. So increased heart rate, increased respiratory rate. And again, I already mentioned the adventitious breath sounds. And adventitious is that word that means abnormal. So this woman, this is another video that I have posted in the module that you should look at. And this is a lady getting oral suctioning with a device called a Yankauer suction device. So you will see that on the video in the module. Nasotracheal suctioning is just what it says it is. It goes through the nose and into the trachea. It is a sterile procedure, and we use, we're going through the nose. The nose tends to be drier usually than the mouth, in some cases anyway. But we're going to lubricate with some kind of water-soluble lubricant when we go through the nose so that the tube can slide through better. We want to measure the suction catheter before we put it into the person's nose. But you have to remember that this is a sterile procedure, so you cannot put it against the patient's face to measure. So when you go to do the procedure, which again, there's going to be another video in your module about this, you insert as far as the distance that you determined by measuring from the tip of the nose to the earlobe to the back of the neck. So if you ever meet resistance, do not force that catheter, because there are a lot of soft tissues back there that you could damage and even poke a hole through. So do not ever force any kind of tube into anybody. So when we put the suction catheter into the person's nose, we are not suctioning or we're not applying suctioning on the way in. We are only applying suction on the way out. So continuous suction on the way out for no longer than 10 seconds, and we use a rotating motion with the catheter. The reason that is done is because usually these suction catheters have holes like on the sides of them. So you want to make sure that you rotate the suction catheter so that you are getting secretions from, 360 degrees of that, of their airway. Make sure that if you are doing nasotracheal suctioning or any other kind of suctioning, that the person is allowed to rest between nasotracheal suctioning. Like some people will, or some nurses, healthcare providers will, want to not only do this one time, they want to, try to get as much out of the secretions as they can, but you need to let the patient rest. And in between suctionings, you want to reapply the oxygen if they have it. So I want you to watch all the videos in the Canvas module concerning suctioning. And before this, COVID pandemic, I had already put some of these little these little videos on in this module because I wanted to make sure that you saw how to collect specimens for the flu, and now they're doing all this COVID testing. So you're going to need to know how to do that in your future. So please watch the video. I generally, if I go to see a healthcare provider and they want to do a nasopharyngeal swab on me, I will do it myself because I don't want anybody poking something in my nose. I think it's a weird sensation, and that's something, that you definitely, if you're swabbing somebody, you want to make sure that they know that it's not the most comfortable thing at all. And when you are taking a swab on a child, make sure that somebody is holding their head still and they're holding their arms down, because you don't want them whipping their head around and again damaging soft tissues in their nose or in their pharynx. So tracheostomy care is part of your skills, or something that you should know. And I've had a couple of people tell me a couple different things as if this was a requirement for the skills lab. But I did not see where you have a tracheostomy care checkoff, but you need to know how to do it. And you will be, it'll be more concentrated in lab as far as tracheostomy care when you get to the 400 level of your nursing school, of this nursing program. So it's good to, just start watching these videos, and you never know when you're going to have a patient that has, might have a tracheostomy, or maybe someone already that has one. So make sure you pay particular attention to the tracheostomy videos that I have in the module. So this is what one of them looks like when you get in there. The one that I posted like this has throughout the video several different um, questions that you have to answer before you can go forward. So when you're watching the video, expect to have the video stop and you have to answer a question. And the only way that you can go on is if you answer the question. The incentive spirometer video is like that as well. And if I have time to make them all like that, I'm going to. So, um, just kind of pay attention to that. Right now, I think they are, a lot of them are just files, but that's just because I wanted you to get the information. But I really want you to learn, so I'm trying to get some of these things, done so that you can answer questions for me and I can see if you can understand what you're doing or what all this is all about. So you might find several in there that are just files, and some of them are on a page. So the ones that are on a page that I have, I think I put them in your to-do list. I want you're going to have to answer the questions. Another interesting thing about those videos is that if you navigate to any other place um, on your computer, it'll stop, and you'll have to resume where you are. So it's kind of a neat little application, and I hope you enjoy it, and I hope you learn from it. So this is something else that is, it's not really a concentration at this level, but something that you should know is chest tubes. And I don't know if you remember me bringing the chest tube, like the sample of the chest tube, to see how big it was and all of that into NUR 220. But I just wanted you to know kind of what it looked like and how they were inserted, that type of thing, if you know absolutely nothing about them. I mean, that's what this class is for, is to introduce you to things. So I want you to get as much exposure as you can. So if you recall that I brought the little model that I had made with the jar and balloons in, just remember that that is all a negative system, and that is like when our diaphragm contracts, when that muscle contracts, the our lungs expand. When our diaphragm relaxes, we push air out. So just remember that it's a negative pressure system. When there's a break in that system and either air or maybe blood or fluid collects in there, it's no longer that negative pressure system. So we need to get that negative system back. So that's what chest tubes are for. So chest tubes remove that fluid or the air so that the lungs can expand again. So it allows the fluid and air to come out, but not back in, because if you can see, there's water in this atrium here. That's just the brand name of the chest tube delivery system here, but there is water in that. You have to fill it, and then you can use have the doctor use the device. So this device is hooked up to the chest tube itself. So something that you need to do is to assess the respiratory system. You want to auscultate lung sounds. Are they if somebody has a lot of blood or air in a place where they usually have lung tissue and alveoli that fill up, you're not going to hear lung sounds. Your lung sounds will be gone. So you have to make sure that you understand that concept. People don't have lung sounds that don't have lung that is right there to hear. So if it's covered up by blood or fluid, or if it's just air in the thorax, you're not going to hear any lung sounds. So that's why it's very important to auscultate lung sounds. You also want to assess the respiratory rate, and how is that patient breathing? Are they doing all right? Are they having eupnea, or are they having dyspnea? You want to look at the drainage. How much drainage are they having? Has the drainage increased drastically over the last hour or two? What's the color? Is it bloody, which is sanguinous, or is it kind of bloody, but yet straw colored, which is serosanguinous? Note any changes in the color or amount. If it changes color, if it changes from a serous straw colored or amber color to bloody, that's probably something that you need to report. Don't you think? Something might have happened within that, chest cavity, and now the person is bleeding. So always be aware of changes in your patient's status, no matter what it is. So we can have complications with chest tubes. We can see a patient have a hemorrhage, so you'd see blood around the dressing, or you'd see a very big increase in blood in the drainage chamber, the collection chamber. The dressing should be occlusive, like the dressings that you've been using in the lab, like the ones you cover up with the IV. We don't necessarily use that type for chest tubes, because usually with the chest tubes we use gauze and then maybe cover it up with that type of clear plastic dressing, only really big ones. The reason I have a picture of the Rice Krispies up here is because the lungs, as you know, are filled with air. So there's air on the inside, there's air on the outside. So what you want to do, this is another assessment thing that you have to do, is palpate around the dressing. So use like the palm of your hand or the flat parts of your fingers to palpate around the dressing on the patient's skin to make sure that there's not air leaking into the sub-Q tissue. That's called sub-Q emphysema. And it makes a sound. I mean, you can't hear it, it's not loud, and it feels really kind of almost crunchy, like Rice Krispies, and that's just the air collection in that tissue. So be aware of that. If the person gets short of breath, check the drainage system or the tube for occlusions. And of course, this having a tube, run through your side between your ribs is not comfortable. So assess their pain level and, make sure that they are in a good position. That you might want to reposition them or give them medication if they need something for pain. Things to remember. We don't ever clamp chest tubes or they don't do their job. So don't clamp a chest tube unless you're changing out a system, which means if that collection system is full and we need to get rid of it, we'll change that out, but we will unclamp the tube. We'll clamp the tube to change it, but then have to unclamp it when we have changed it. If that chest tube comes out, you would cover the hole that's in their side with a dry, sterile dressing and hold it there. Another thing is you want to make sure, remember I said there was water in those collection systems. You do not want to let it tip over, because if it tips over, there goes your, negative pressure that you're trying to restore. So it kind of defeats the purpose. So they're on the sides of these collection systems, they usually have little hooks that you can secure them to the bed frame so that they don't fall down or tip over. So now we're going to move on to the circulation portion. And again, in the module, let's see, I don't remember where I put it. In the module somewhere, I reposted that heart quiz on Canvas that will show you like the different structures of the heart, and just to remind yourself of where these structures are, and kind of revisit how the blood flows through the heart. Because again, you need to know this so that you need to know how things work normally, so that when they're not working normally, you'll know like some symptoms. You'll understand why people are getting the symptoms they get. In 220, I had posted some, there was a little video on placement of the electrodes for EKG monitoring, and I think that I drug that over and put it into 230 now. So it's probably in your module here in 230. So make sure you watch that as well. So you can tell by the picture on this slide that we have 5 electrodes. Some places use telemetry, and telemetry is different than there's telemetry and there's hardwire monitoring. Hardwire monitoring is generally used in ICU because there's a cord that is hooked up to this, and people cannot walk around. Telemetry, people have a lot of times they only have 3 leads, but I've seen in town here, I've seen 5 leads mostly. But they can get up and walk around because they've got like a remote system where they can be up and about and walking in the hall and that sort of thing. But somebody can still look at what their heart rhythm is. So just kind of look where these are, and this is where the electrodes are placed on the chest wall. And then when you go to put the actual wires on the patient, they are color coded. So there's that little video. I'm not even going to bother here to tell you about it because this is not color coded, but it's going to tell you on the video about the color coding and how you can remember where the different colored leads go. So circulation, promoting circulation. How do we best promote circulation in our patients? Like, what is the best way that you know to promote somebody's heartbeat, heart pumping, and blood flow, and all of that? What is the best thing you can do? Just think about that for just a couple seconds. I'm going to be quiet. You think about it. Silence is crazy, isn't it? So, yes, I heard crickets. Nobody answered me, and I don't have your little sticks here that I can pull a name. So, yeah, very funny, right? Um, but anyway, so the best way that we can promote circulation in our patients is by getting them up to walk, ambulating them. That best promotes their circulation, gets the heart pumping, it helps move the blood up the legs through the like muscle contraction in our calves and in our thighs. It gets the venous blood moving. So that promotes circulation. Well, some of our patients can't do that. Some of our patients are either maintained on bed rest for various reasons, or they are post-surgical and need to maintain some type of bed rest, or they just don't want to, they're not going to be mobile. Let's see, another situation many times is that postpartum, or women who have had babies will have, or who have had, who have had a C-section mostly. Number one, they're post-surgical, and number two, they are in a hypercoagulable state, and you'll learn that when you get in the OB class. But so we have to be mindful of what risks our patients are at. So one of the things that we can do to help promote circulation is sequential compression devices. So you will see on here that the stockings, we call them the stockings part, are on the lower legs. They do have some that are like thigh and like around the thighs and the lower legs. So it just kind of depends on what your facility has or what the doctor orders. And these are not difficult to use. So sequential compression devices are appropriate for people who are immobile on bed rest, are very prone to blood clotting, or the word is hypercoagulable. So I don't know if you've heard of factor V Leiden before, but that is a gene blood disorder, and people have a blood clotting tendency. So the other way to promote circulation in patients is by thromboembolic disease hose, or TED hose for short. TED hose, if you notice by the slide here, the picture on the slide, there are numbers on the picture. Upper thigh, 8 millimeters of mercury, the lower thigh, 10 millimeters of mercury, popliteal, 8 millimeters of mercury, calf, 14 millimeters of mercury. So what that tells you is that is how much pressure is maintained in each of those areas. So what if I was a, like little tiny person, and somebody got me a pair of large TED hose? Well, they'd probably be falling down to my knees or my ankles. So there's no purpose in that. So how we know what size our patient needs is measuring like literally measuring with a tape measure the thigh, the upper thigh, the lower thigh, the popliteal area, the calf, and the ankle, and we can determine their TED hose size. A lot of times nurses just guess at this, which is probably pretty common practice, but that is really not the standard of care that we should provide to our patients, because we don't know if we're providing, what if we're providing too much compression? That isn't good either, because then it is cutting off blood circulation. So we have to do what is best for our patients. So here is, again, showing the stockings and just the SCD pump or the device. And as I've explained already, and you might know anyway, the it's sequential, meaning that it puts air in and takes air out. So it blows up and lets the air out. And it mimics what would be happening if we were able to walk. So, or if the patient was able to walk. So again, just here is, there will be another video in your module that will look like this, and it is on SCDs. So in that video that you watch, there will be a word or words, terminology called Virchow's triad. So it was mentioned in the video, and it consists of 3 factors that may dispose a person to the development of clots in their veins. And what we call that is venous thrombosis. The factors include, here's the word again, hypercoagulability, or a tendency of the blood to clot. Hypercoagulability. Stasis, blood pooling or standing still in the arteries and veins. Because you have to remember that in our arteries have blood that's being pushed by the heart. So it goes from the heart to the arteries to the veins, So there's arteries, arterioles, and then capillaries, and more capillaries, and then it gets to the veins. So there's not a lot of pressure to push the blood along once it gets to the venous side. So we need to be mobile, and our patients, we want them to be mobile, but sometimes they just can't be mobile. So blood will pool and stand still, and that's called, there's no movement. So if there's no movement, the terminology for that is static. Something is static. It's standing still. So venous stasis is blood pooling or standing still. So then the third thing in this triad is endothelial injury. So when we talk about our veins and our arteries, they're very slick on the inside. The endothelial tissue is very slick. So if that has been damaged by, let's say, inflammation, and platelets will start to aggregate there or cling to that spot, and then more platelets and fibrin and fibrinogen and red blood cells, they all get stuck there. So that is another risk factor in this triad which predisposes a person to the development of venous thrombosis or blood clots. So that ends this this session on circulation and oxygenation. And this was approximately, right now, it's exactly an hour long. So when you do those videos and the video quizzing, it will probably, um, you know, it'll all add up to the amount of time you would have otherwise been in class. So again, if you have any questions, please post questions to me. You can post comments to me. You can comment to me in my email. Um, and I will see you in a Zoom session soon. I'm looking forward to it. See you later, and wash your hands and stay well.